Ma'am.
Good afternoon, everyone. Welcome to today's Facebook Live session. I'm Dr. Keerthana, consultant and fertility specialist at Oasis Fertility, Tolichowki. And today I have come with an interesting topic, which is fertility preservation, which we all need to know about the fertility preservation because of the changes in the lifestyle and increase in the incidence of oncological conditions these days. So basically, fertility preservation, it is a fundamental need for the individuals of reproductive age or prepubertal boys and girls whose future fertility may be compromised. So it is important to understand that reproductive capacity is usually affected by age, genetic syndromes, or something like taking gonadotoxic treatment. In a fertility preservation, so it is important to understand that all individuals wishing to preserve their fertility, it is important for them to have adequate counseling about the available fertility preservation options and timely referral to a fertility specialist to inform what are the options available and to know about the decision making. That is very important. And when we talk about the indications, what are the indications? When do an individual need to have fertility preservation? When we talk about the indications, so the indications are like oncological indications for fertility preservation and non-oncological medical fertility preservation and delayed childbearing, that is elective egg freezing. So when we talk about the oncological conditions, because what happens in these oncological conditions is that when a patient is asked to undergo a surgery or oncological treatments like chemotherapy or radiotherapy, because these interventions are proven to cause damage to the gametes, that is, they are gonadotoxic, and because this damage is again irreversible, so they need to have the fertility preservation before undergoing these treatment procedures for their oncological condition. So, what are the oncological conditions that needs fertility preservation? Are some of the systemic diseases like Hodgkin's lymphoma, non-Hodgkin's lymphoma, or any form of hematological malignancies like leukemias. And what are the other forms of pelvic or gynecological cancers that needs fertility preservation is like early stage cervical cancer, early stage vaginal cancer, endometrial cancer, or cancer of the ovary, and some extra pelvic or non-gynecological malignancies like pelvic sarcoma, bone cancer, osteosarcomas, say it, breast cancer or bowel malignancy. In such conditions, it is very important to undergo fertility preservation before embarking on any forms of cancer treatment. And now, after the oncological indications, medical non-oncological indications, like in case of some autoimmune diseases like systemic lupus erythematosus or what is called as rheumatoid arthritis, or in case of medical conditions that cause premature ovarian insufficiency, basically which decrease a woman's ovarian reserve, like any ovarian oophorytis, benign ovarian tumors, or fragile X mental retardation, mosaic Turner syndrome, or in case of galactosemia. These are some of the medical non-oncological conditions that wherein fertility preservation has to be attempted for. And after the non-malignant conditions, it's the what we call as the elective egg freezing, or the delayed childbearing, because increasing proportion of the women these days, they choose to have children later in the life, that is after 35 years of age. So elective egg freezing has been proposed as oocyte cryopreservation in these areas. So, what is the effect of these chemotherapy or radiotherapy on the cells? What happens because of these cancer treatment options on the gonads? Or what happens is that because of the use of chemotherapy can lead to the fast loss of eggs. That is, it has its effect on the different stages. That is the follicles will get affected by direct or indirect action, basically leading to the loss of the primordial follicles. And also the cell type or the cell stage is also will be affected, wherein it causes the death of the oocyte or damage to the somatic cells, wherein the growth of an oocyte usually happens. So after that, what are the chemotherapeutic agents? So which have an adverse effect on the gametes, or what? How can we categorize these chemotherapeutic drugs based on their risk of causing premature ovarian insufficiency? Is that there are certain group of drugs like alkylating agents, basically like cyclophosphamide or busulfan, which they are more gonadotoxic and they cause DNA breaks, or which are usually cell cycle non-specific, and because of which the risk of premature ovarian insufficiency is more than 80%. And there are some moderate risk drugs which cause the risk of premature ovarian insufficiency in between 40 to 60%. The drugs like cisplatin, carboplatin, and doxorubicin, etoposide, or such a group of agents which have a moderate risk of premature ovarian insufficiency, that is 40 to 60%. And the low risk ones, that is which have the risk of less than 20% of the risk of premature ovarian insufficiency, are like some drugs like bleomycin, actinomycin D, vincristine, methotrexate, and these are some of the drugs which have less than 20% risk of premature ovarian insufficiency. And then the chemotherapeutic, after knowing about the drugs according to their gonadotoxicity level, so next what is important to understand is that, so how do these cancer treatment, how do they have their overtoxic effect? Now, what is the overtoxic effect of these chemotherapeutic drugs or the radiotherapy as such? Is that the radiotherapy overtoxic effect basically depends upon the age at which the person is undergoing the treatment, the dose of the radiation therapy, and also the fractionation schedule. So on it has its deleterious effects on the ovary, it has its effects on the uterus, also on the brain. So when coming to the ovary, so toxicity is due to the direct exposure or what is the scatter radiation. So in case of any pelvic or abdominal, or there is total body radiation, there is high level of gonadotoxicity is usually expected. And the degree of the damage, so it also depends upon the dose of the radiation. So when the total dose of the radiation is more than 12 gray, it causes a significant uterine dysfunction. And in the childhood, when the direct exposure of more than 25 gray can cause irreversible damage. And then after knowing about the effects of the radiotherapy and how are they gonadotoxic, it is important that to know that because of the radiotherapy, it will interrupt the normal cellular proliferation in a cycle and causes extensive cell damage. So if that exposure happens before puberty, the ovary is usually less vulnerable, because at that point of time there are higher number of oocytes that are present. And with abdominal radiotherapy, there is usually a high risk of premature ovarian insufficiency. And the total radiation dose, if it's 20 gray, that has a fractionation over 6 weeks in a young female and in children, it produces sterility with about 95% confidence. And also, it is also important to know that the dose of radiotherapy is usually inversely correlated with the age. That is, at birth, the radiation dose of 20 gray will cause irreversible damage, and with increasing age, that is at 20 years, it requires something close to 16 gray, and at the age of 40 years, it requires a dose of about 11 gray. That is, with increasing age, the dose gets reduced. That is, there is an inverse relationship. And what happens because of these radiotherapy treatment, what happens in a male, it is that these gonadotoxic agents, they lead to permanent oligospermia or azoospermia, and the changes are usually seen 90 to 120 days after giving the alkylating agents, and the dose as small as zero point 0.1 gray also can impair the sperm production, and up to 1.2 gray can cause permanent azoospermia. And then so now, what are the fertility preservation options after understanding what is the effect of these chemotherapeutic agents, radiotherapy, how are they gonadotoxic, how do they cause the damage? Next, it is important to understand what are the fertility preservation options that are available in a female as well as a male. So when we talk about the fertility preservation options in a woman, the standard, it includes the standard methods and also the experimental methods. The standard methods are like pelvic shielding, or the ovarian shielding, that is shielding by use of some lead shields in case of abdominal or pelvic radiation. But in case if the ovaries overlap the radiation field, then the shielding is not possible in such cases. Then what is important in such cases is the ovarian transposition, or the oophoropexy is a fertility sparing option, where the ovaries are usually surgically, they are moved outside the pelvic area or the radiation field. And the other method is the mature oocyte or the embryo cryopreservation after control ovarian stimulation. So this mature oocyte cryopreservation or the embryo cryopreservation, it is a first line fertility preservation method, and it is the established option for the fertility preservation. So, and it is important to know that it is the most simple, safe, and effective option to preserve gametes in both elective egg freezing and oncological fertility preservation. So the control ovarian stimulation can be it can be initiated at the start of the cycle, which is a conventional start, or it can be started at any day of the cycle, which is a which we usually call as a random start protocol. And then in control ovarian stimulation for fertility preservation, the in estrogen sensitive tumors like breast cancer or the endometrial cancer, along with the concomitant use of the concomitant use of this some oral agents like anti-estrogens like letrozole, it will maintain the low estrogen levels, and it will not aggregate the or increase the ongoing disease process. And it is also important to know that this fertility treatment in BRCA1 or BRCA2 mutation carriers also, wherein there's a risk for ovarian cancer or the breast cancer. And this also shows that there is no increase in the risk of the ovarian cancer, and these carrier persons should not be excluded from this fertility treatment. And after the mature and the embryo cryopreservation, the other method of fertility preservation is the ovarian tissue cryopreservation and the ovarian tissue transplantation. That is removal of the ovarian tissue prior to the cancer treatment. It may be the only method of fertility preservation that is available in certain age groups, like the prepubertal female, or those who do not have the time to undergo the ART procedure prior to starting the cancer treatment, or those who cannot tolerate these supraphysiological hormonal exposures that is required for the most ART procedures. And in women with some hormone sensitive malignancies also, the method of fertility preservation is the ovarian tissue cryopreservation and the ovarian tissue transplantation. And after this, the oocyte and the embryo cryopreservation, and the experimental methods include, in case of breast cancer, which the concomitant use or co-administration of GnRH agonists along with the chemotherapy may also have some protective effect on the ovary, but this is proven only in case of CA breast and not in the other conditions. And then the other upcoming method or the experimental method is the in vitro maturation, that is the IVM. So in fertility preservation, IVM, it can be offered as an alternative when conventional ovarian stimulation it is contraindicated, or when the time available before the start of gonadotoxic treatment it is short and it cannot be delayed for the sake of ovarian stimulation treatment. So what happens in IVM is that immature oocytes can be aspirated in vivo from the unstimulated or the mildly stimulated ovaries, and then they are matured in vitro, and then they can be frozen and ICSI can be done at a later date. So IVM should be regarded as an innovative fertility preservation procedure, and which can be embarked upon. And then after talking about the fertility preservation options in a female, then in a male, what are the fertility preservation options that are available? So for men and post-pubertal adolescent men who choose fertility preservation, so masturbation and sperm cryopreservation, it is a gold standard method of fertility preservation that is available. And other method, if we talk about, is the testis shielding, that is which protects the testis during the radiation therapy, or the sperm banking. So the mature sperm, it is usually obtained and frozen by masturbation or by using vibratory or electroejaculation, and recovery of the ejaculate sample, and then it is frozen. Or sperm extraction, that is if the patient is unable to provide a semen sample, sperm cells can be surgically extracted from the testis or epididymis and then frozen. So, and the experimental methods include the testicular tissue cryopreservation, which is the only option that is there for the prepubertal oncological patients who cannot produce a semen sample, and that is the method that is available for these prepubertal men. So, to summarize, all the patients undergoing gonadotoxic treatment, they should be informed about the risk of fertility loss because of the cancer as such, or because of the treatment, because of the treatment that they are using. And all the patients at risk of loss of fertility should be referred to a fertility specialist. And oocyte cryopreservation, it is the option for the post-pubertal females, and and there is no male partner. And in case of embryo cryopreservation, it requires a male partner. And oocyte ovarian tissue cryopreservation and transplantation, it is still in an experimental stage. And in a male, the fertility preservation options include the sperm cryopreservation and the testicular tissue cryopreservation. And the experimental stages in a male on the limited resources and high cost and lack of awareness, they are some of the important barriers that we consider in case of fertility preservation. So, if this is all about fertility preservation today, so if you have any other queries, you can comment. So, the query that we could see is who needs fertility preservation, like how we discussed, the indications being an oncological indication, that is a person is told to have any condition like any cancer or some non-oncological medical condition like any systemic lupus erythematosus, endometriosis, or in case of mosaic Turner syndrome, Klinefelter syndrome, some oncological, non-oncological conditions, and the delayed childbearing. So these are the some categories of people who will require fertility preservation. So if there are no more queries, we can conclude the session for today. Thank you.